Okay, Assalamualaikum and a very good evening to all participants. On behalf of CME MedTweetMY Professional, I am delighted to welcome everyone to our last CME of 2024 titled The Kidneys. This program is organized to provide healthcare professionals with the latest updates in nephrology, featuring two highly accomplished speakers who will share their expertise on the critical topics in kidney care. I am Adila, your moderator for today. We deeply appreciate your participation in this session. Thank you for taking the time to join us tonight. Before we proceed, here are a few housekeeping reminders. If you have questions for our speakers, kindly type them in the Q&A box and we will address your questions after our second talk. Certificates for the attendance and 2 CPD points will be provided at the end of our CME, and it will only be given to those who join via Zoom platform. Please ensure you fill up the form correctly to receive these benefits. So tonight's program consists of two key topics delivered by two renowned experts in their field of nephrology. Today, we will explore an important topic in clinical medicine, acute kidney injury. A nationwide survey revealed that AKI affects approximately 15 to 20% of hospitalized patients, with a higher prevalence in critically ill individuals. This underscores the importance of early diagnosis, prompt management, and preventive strategies tailored to our local population. And today, we are so lucky to have Dato Dr. Lily Mushahar, a highly accomplished nephrologist. She is the head and consultant nephrologist of the Department of Nephrology Hospital Tunku Jaafar Seremban, and also served as the head of Clinical Research Center of Negeri Sembilan, Malaysia. Dato Dr. Lily received her undergraduate and postgraduate degrees from USM and completed her nephrology fellowship training in United Kingdom. She is currently serving as a president of the Malaysian Society of Nephrology, MSN, for the term 2022 to 2024, chair of the membership committee for the ISPD, chair for the CME committee for the Asia Pacific Society of Nephrology, and also the ISPD committee of HTJ Seremban. So without further ado, let us begin with our first topic. I now invite Dato Dr. Lily Mushahar to present her talk on current consensus in the management of acute kidney injury. So Dr. Lily, the floor is yours.
Assalamualaikum warahmatullahi wabarakatuh and a very good evening everyone. Thank you Dr. Adila for the kind introduction. Just a correction that I'm now the immediate past president of Malaysian Society of Nephrology. First and foremost, I would like to thank you, the MedTweet professional team, for inviting me for this webinar to share with you my talk, where I've been given the task to talk on current consensus in the management of acute kidney injury or AKI. And I think Dr. Adila have mentioned that AKI actually is a very important issue that we have not only in Malaysia but globally. And acute kidney injury or AKI ranges from about 114 to 174 per 10,000 person years. And the global burden of AKI-related mortality actually are much higher than breast cancer, heart failure, or diabetes. And if you look at the what are the incidence of AKI in high-income country versus low-income country, actually they're quite different. In terms of when in high-income countries, they are more predominant in hospitalized elderly patients, or they are also have underlying related to sepsis, drugs, or invasive procedures. Whereas in low-income country, or they have predominantly infection and hypervolemic shock.
Sorry,
So
Dato,
what is
slide, Dato. Share your slide, Dato.
Oh, sorry. Okay, I'm sorry. I thought I shared already. Hold on. share. Can you see now my slides?
Yes, yes. Sure, Dato.
Okay. Okay, I just showed you. I apologize for that. So what are the incidence and magnitude of AKI or acute kidney injury in Malaysia? And it has been shown that 24.2% of patients admitted to ICU had AKI within 24 hours of admission. And our Malaysian data, which was published by Azrina et al., has shown that 65% of the incidence and mortality rates of AKI is about 55%. And the risk factor in our Malaysian population are mainly septicemic shock, gram-negative bacteremia due to vasopressors, mechanical ventilation, use of RAS inhibitors, and underlying CKD or chronic liver disease, diabetes, and hypertension. And this is a paper of a review article done by Jackson Tan et al. And they have divided into the different countries into the high income countries and the middle and lower income countries. And Malaysia is there. And you can see that in Malaysia, about 24.2% of those 26,000 patients admitted to ICU had AKI within the 24 hours of admission. And from this paper also, it shows that the lower income countries has higher rates of AKI, and the common factors are advanced age, pre-existing kidney disease or medical disease, obesity, and high warning scores. And this is our own paper by the nephrology team, which was published last year in Malaysia Medical Journal. And this paper, actually, we did a study in 5 tertiary hospitals in Malaysia. And we screened the hospitalized patient in terms of the serum creatinine. And 21,000 of the patients were screened, and the incidence of AKI in ICU was about 26.3%. And 7.2% of those patients required dialysis, where 14.6% actually required continuous kidney replacement therapy. And if you look at our population in this paper, looking at the survival, you can see the worst survival are those who are admitted to ICU. And this is followed by those who have cardiovascular comorbidities like heart failure or ischemic heart disease and caused by sepsis. So the risk of having AKI is also if related to sepsis about 22 to 69%. And in sepsis-associated AKI, 15 to 20% of the patients develop severe stages of renal insufficiency and need kidney replacement therapy. And this is a paper which is in publication, which is supposed to publish in nephrology dialysis transplant about heart failure. Heart failure is quite common, especially in Malaysia, and because of our high rate of diabetes. And AKI is common in heart failure in terms of because of the organ crosstalk we are well known about, where the kidney and the heart actually have an adverse impact among each other. So when there's kidney failure, it impacts on the heart. And when the patient has heart failure, it also causes a reduce in renal hyperperfusion and renal congestion. And both of these actually contribute to the low GFR. But it is very important to realize that venous congestion is due to the increased right-sided heart pressure in acute heart failure, and it is a major cause of kidney dysfunction. And we tend to use a lot of diuretics to decongest this patient. And when we use a lot of diuretics, you can see that the serum creatinine and the blood urea starts to climb up. And then we start to worry about what is the effect on the kidney after we're trying to save the heart. So later I will discuss on how to manage on this group of patients. So in acute kidney injury, we need to know what's the definition, right? So acute kidney injury or AKI is defined by alteration in the kidney function markers, which is the serum creatinine and the urine output. And the duration occurs less or equal to 7 days. And AKI actually is a part of a group of acute diseases, which is called AKD. And although AKI is reversible, but slowly, if we do not correct that, there are some group of patients who has AKI will slowly deteriorate and persistent have kidney dysfunction. And this will lead to irreversible loss of kidney function, and they can develop chronic kidney disease or CKD. And what do we mean by CKD? It actually means persistent, which is more than 3 months, alteration in kidney function, and both AKI and acute kidney disease can occur in patients with or without precedent chronic kidney disease. And they tend to overlap with AKI, acute kidney disease, and CKD. However, in patients who do not have kidney disease or NKD, they do not overlap with any of these entities. I'm sure that most of you all know, I know that the audience are from different group of background. So I try to tone down my presentation to allow majority of you all understand on this presentation. And for AKI, if you follow the KDIGO guidelines or KDIGO staging, it has 3 stages, mainly looking at the criteria of 2 biomarkers, which is the serum creatinine and the urine output. So the stages are stage 1, 2, and 3, where in stage 1, the creatinine, if the creatinine goes beyond of 26 micromole within 24 hours, or it goes 1.5 to 2-fold increase from the baseline, and the urine output drops less than 0.5 mils per kg per hour for 6 consecutive hours. And stage 2, if the serum creatinine goes more than 2.3-fold from baseline, and the urine output drops less than 0.5 mils per kg per hour for 12 hours. And the stage 3, which is the most severe one, when the creatinine is increased 3-fold from the baseline, or the serum creatinine goes beyond 354 micromole and needs to initiate kidney replacement therapy, and the urine output is less than 0.3 for 24 hours or anuric for 12 hours. However, this categorization of AKI staging has its limitation, where this categorization will not work if you do not know what's the baseline of the creatinine of those patients, and or even if the patient has underlying CKD and has not been any follow-up and doesn't have any records of their creatinine before. So this is the limitation of having the AKI staging. And the other thing of the limitation is, especially in patients who will undergo major surgery, we tend to hydrate or infuse large amount of fluid, and this will dilute the serum creatinine, and this will interfere with the serum creatinine of those patients. And of course, when a patient is critically ill, sometimes your serum creatinine doesn't reflect the true eGFR of that patient, because when the patient is losing muscle bulk, the serum creatinine will be very low as compared to the true eGFR. And if the baseline creatinine, for example, is at stage 2, when the patient comes with a creatinine of 177, so that patient is actually stage 2. But however, if the baseline goes double, more than 374, for example, then you may not sure whether this is actually stage 2 or stage 3. And this is quite an interesting graph by Callum et al., where to show that what happens to our GFR when we age, number 1, where when we start to age, normal aging, our GFR starts to drop by at least 0.77 mils per minute after our age of 30 to 40 years. And if we can look at this graph, you can see that this red line, this is the normal aging process, where we tend to lose our GFR each year of our age. And the green is the average lifespan, whereby if we lose our eGFR of 0.75 at the age of 45, for example, when we age at 75, which is our average lifespan in Malaysia for male or female, the eGFR, or when they develop end-stage kidney disease, it will be beyond the lifespan of those patients. So the patient will die before they land on dialysis. However, if the patient has developed AKI at a very young age, which is this dark blue line, how it depends on the eGFR level. If the AKI develop at a high GFR level, you can see that the trajectory of the development of drop of eGFR until end-stage kidney disease will be much, much longer as compared to when the patient develop AKI at young age, at a very low eGFR. So you can see how is the trajectory between the different eGFR at different at the young age. However, in elderly patient, in an old age, you can see that the drop of EGFR is much faster, irrespective of the EGFR level. And we need to be aware the consequence of AKI. And when a patient develop AKI, it will cause a dynamic systemic consequences in terms of the brain, where the patient can develop encephalopathy because of the uremic toxin causing altered sensorium and seizure, heart failure with the fluid congestion and fluid overload and hyperkalemia, intestinal and microbiota disruption. When the patient is congested, they can have gut edema also, and this will cause intestinal and microbiota disruption. And also bone marrow systemic effect because of the uremia, it can cause bone marrow suppression, causing cytopenia and systemic inflammation, acquired immune deficiency, liver dysfunction because of fluid overload also, and lung injury, mainly because of fluid overload and also microvascular injury. So all in all, this cartoon shows that whenever a patient has kidney injury, it will affect multiple organs in the body of those patients. And this is an article which is done in Malaysia on prevention and early detection of AKI intensive kidney units. This is actually a systemic review, about 20 articles, 3 were done in Malaysia. And they saw that those patients in the intensive care unit, the high risk were those having heart failure. Remember, I alluded earlier that heart failure and the kidney actually will talk together, and they will interact together, and they can cause drop in EGFR. If the patient has liver disease, CKD, and past history of AKI. So next, I would like to highlight to you what are the biomarkers and what are the clue that the patient has AKI. Our main biomarkers, if you remember from the AKI staging of KDIGO, the clue or biomarkers are 2, the serum creatinine and the uric output. And the serum creatinine is one of the most available in our clinical practice, even in our general practitioner, and is one of the best marker used in AKI detection and recovery. And it is recommended that when you suspect a patient has AKI, regular serum creatinine monitoring is a must for patients with a high risk of AKI development, where in intensive care, usually we require to perform serum creatinine at least twice a day or daily. However, the problem with serum creatinine, it has a very low sensitivity, as it will only start to increase after at least half of the GFR is lost. And I've alluded earlier, if the patient has muscle loss, it also will interfere with the reading of the serum creatinine. So therefore, there's a lot of functional biomarkers of AKI coming up for the past few years. And it actually looks at the origin and function of biomarkers, where these biomarkers are able to detect 1 to 2 days before the serum creatinine becomes abnormal, either in the blood or in the urine. So you can do these biomarkers, functional biomarkers, not only using the blood test, but also the urine. And if you look at the label of the green, which is a functional biomarker, the blue, which is a stress marker, and the red is the damage marker. And NGAL, which is a neutrophil gelatinase lipocalin, is one of the biomarker which has been investigated for many years, and up to today is not really available widely in our clinical practice. Maybe in the Ministry of Education or in the universities, they may have performed these biomarkers in their unit, but not in the Ministry of Health. And the other thing is the KIM1, and also other biomarkers that is available, and the TIMP and DKK3, which is the stress marker, which a lot of researchers are looking on. So we hope in the future, in Malaysia especially, these biomarkers can be available in our clinical practice, where we can detect the subclinical AKI rather than just waiting for the serum creatinine to be abnormal. And when we look at the categorization of AKI based on using these biomarkers, which is a damage or stress and functional biomarkers, actually we can have a prognosticate the patient, where, for example, in this box, if the patient has no damage in the kidney function, and the biomarker is negative, so their restoration of function is very good, their prognosis are very good. However, in the red box, if they have alteration in the serum creatinine and the biomarker is positive, and they have also loss of function, where clearly they have AKI, subsequently they can have moving to the right side, they will lose function and progress to chronic kidney disease. Another thing of the biomarker, which I said earlier, is the urine output. I think we should really monitor our urine output whenever we are suspicious of AKI. And this is a paper by Tanda et al. They are looking at intensive and less intensive monitoring of urine output. And the definition of intensive monitoring of urine output is monitoring hourly with no gaps of more than 3 hours for the initial of 48 hours after ICU admission, and daily monitoring respectively. And they noted that those patients with AKI who undergo intensive urine output recording was strongly associated with improved survival to 30 days and less proportion of about 10% fluid overload. I think the reason is when we monitor the urine output, we can tally it with the fluid resuscitation that we are giving. And of course, and the other thing is, if we just not monitoring the urine output, just putting the patient on Pampers, and we say the Pampers is dry, there's no urine output, and we are just weighing the Pampers, I think that's not accurate. And some of the patients we may miss that actually they are having acute kidney injury recovery, where the kidney starts to opening up and the urine output starts to improve, and we are not hydrating the patient adequately, and this can cause dehydration and slow the progression of kidney recovery. And this is another graph that's to show you that please bear in mind that in a patient who has developed acute kidney injury, especially stage 3, along their lifespan, that they can develop chronic kidney disease at one point of time during their lifespan, they can end on end-stage kidney disease and require kidney replacement therapy. So that is why that it is advisable that any patient who has acute kidney injury, we should not just discharge them from our clinics and lose them from our radar, because subsequently along the years, they may develop chronic kidney disease and not detected. I know it's quite challenging to follow up all AKI, even in our nephrology clinic. But what we do is we try to get the help of our primary care and primary physician to follow up in their clinic, even though they have a complete resolution of the acute kidney injury. So to allow us not to miss in the future if they develop chronic kidney disease. So what are the current therapeutic approaches in acute kidney injury? I think the first one is just to make you all be aware that early goal-directed therapy is very important in terms of resuscitating the patient. If a patient has septic ischemic shock, a 6-hour resuscitation protocol need to put in place. And this is the list of criteria. What are the resuscitation protocol to maintain with is looking at the CVP, where we need to maintain more to 8 to 12 millimeter mercury, maintaining the mean arterial pressure of more than 65, maintaining the urine output more than 0.5, central venous oxygen saturation more than 70%, and hemoglobin of 8 grams per deciliter. And this is a publication where they look at 28-day mortality, looking at the standard therapy and the early goal directed therapy results. It shows a significant reduction of mortality. So EGDT, or early goal directed therapy, actually has been shown to improve patient survival. What about antimicrobials? In the patient who has sepsis, we need to initiate antimicrobials as early as possible, because for every hour of delay in initiating antibiotics in septic patient, the risk of AKI actually increases especially after 3 hours. And Backshaw has showed that how immediate antimicrobials initiation and the time of hypotension actually affect the risk of incidence of AKI. Next is fluid resuscitation. How much to give? As previously I mentioned that early goal-directed therapy, we need to resuscitate the patient at least within the 6 hours. But however, we always need to monitor the urine output. And how we resuscitate the patient is we should at least infuse 30 ml per kg of IV crystalloid to be given during the first 3 hours of resuscitation. However, this is quite weak, and if the urine output does not improve or the patient is anuric within the 3 hours or 6 hours resuscitation, we need to step back in our fluid resuscitation, because perpetually the patient can develop fluid overload, and in the end we have a risk of ventilation and a poor lung perfusion. So fluid overload, actually, sometimes if you are not careful, it can mix the poison to the patient. And a fluid overload is also a biomarker of critical illness. And this can lead to interstitial kidney edema and intra-abdominal hypertension. And actually, fluid overload also is a predictor of mortality and cause worse renal recovery. So a positive fluid balance is associated with a worse outcome in patient with AKI, especially in anuric patient. So please be careful whenever we want to resuscitate patient, give a timeline, whether you want to resuscitate at within the 3 hours or 6 hours, and by 3 to 6 hours, if there still are no urine output, despite your fluid resuscitation, you have to step back and reduce your fluid resuscitation and also your fluid input. So previously I mentioned about AKI and heart failure. Just to highlight that sometimes we are worried that if we diurese the patient too much, it can cause dehydration, hypotension, and the creatinine starts to creep up. So this paper showed that actually when we start to worry, so they use a traffic light system. And this is by Banerjee et al., which is in the publication for, next year in 2025, that if the patient has AKI with decongestion and no UTI, sepsis or CRP, and we should not worry. However, if the patient has sepsis, UTI, and the CRP is higher with the evidence of sepsis, then we may need close monitoring. And but we really need to worry when the patient develop AKI stage 2 and 3 and no decongestion, and the patient has sepsis, UTI, and the CRP has gone beyond 100. Another thing is sometimes we are a bit worried of initiating SGLT2 inhibitor, where not only cardiology but nephrology, we are using the 4 pillars, where SGLT2 is one of the pillar coming in to protect the patient to develop heart failure and also CKD progression. And the mechanism of AKI, rising creatinine in heart failure on starting SGLT2 inhibitor is as shown here. And we may need to just monitor the creatinine trend. And if you think is in future, as the patient progress, the heart failure worsen or the chronic kidney disease worsen, so we just need to monitor the use of SGLT2 inhibitor in this group of patients. So if we're talking about fluid resuscitation or fluid overload, so does it mean that we have to make the patient more dry, right? So this is a paper on restricting fluid strategy in septic shock in patients who has in ICU setting. And they noted that they divided into 2 groups. One is the restrictive fluid group, where the median fluid resuscitation was about, or fluid input about 500 to 4 liters, where the standard group is median about 3 liters up to 6 liters of hydration. And they look at the outcome of the prior outcome in terms of the standard fluid group and the restrictive group. Those restrictive group there were no difference in mortality And there were also no difference in terms of serious adverse event and severe AKI. So in conclusion, from this paper, among adult patients with septicemic shock in ICU, IV fluid resuscitation did not result in fewer deaths at 90 days than the standard intravenous fluid therapy. So I think we just need to balance the risk or benefit to make sure the patient is not overhydrated and the patient is not dehydrated. So we need to monitor the patient. That's why we need to monitor the patient regularly in terms of doing the serum creatinine daily or BD and monitoring the urea output hourly, and also please be judiciously using our fluid resuscitation. And so therefore, we should apply the ROSE concept, which is optimization of our fluid using the first hit initial insult with and subsequently followed by the ischemia perfusion, and also the risk by the fourth hit with the risk of hyperfusion, where the first one is rescuing the patient of fluid resuscitation, and the second one, O, is organ rescue, where we just maintain the fluid hydration, and S is stabilizing the patient, focusing on the organ support, and finally looking at the evacuation phase on organ recovery. So besides fluid resuscitation, I think whenever a patient has AKI or acute kidney injury, we always need to monitor the blood gases, the metabolic acidosis, because acute metabolic acidosis is well recognized, especially in sepsis-associated AKI, and it has such a detrimental effect on cardiovascular system, where in patients who have severe metabolic acidosis, the heart will decompensate and cause hypotension. Sometimes you need to put up double inotrope and triple inotrope if you do not correct the metabolic acidosis, address it early. And so what is the roles of sodium bicarb therapy in correcting metabolic acidosis in this group of patients? So this is a paper looking at the bicarb ICU trial using bicarb therapy intravenously for severe metabolic acidosis. And you can see that they are randomized 1-to-1 when a patient with no bicarb correction at all versus another group which is using sodium bicarb, and their pH they are targeting for the no bicarb is less than 7.3, and those with sodium bicarb is more than 7.3. And if you look at the primary composite outcome, which is the mortality and the organ failure, which is more than organ failure, there were no significant difference between these two groups of no bicarb or bicarb therapy. However, it is interesting to know, looking at the renal kidney replacement therapy, we can see that those who we correct with intravenous IV bicarbonate, sodium bicarbonate, actually it delays the indication for kidney replacement therapy very, very significantly. In the sodium bicarb group, 52% doesn't require kidney replacement therapy compared to 35%. So I'm sure that most of you, when you develop, when you encounter a patient on AKI, you may refer the patient to a nephrologist. So Go et al., our local paper noted that 16 out of the AKI in Malaysia in the intensive care, only about 16.9% were referred to the nephrologist. And the main indication are metabolic acidosis followed by uremia and electrolyte disturbance. So next, I will just go through with you what are the kidney replacement therapy if our medical therapy or fluid resuscitation does not work. And in our Malaysian Registry of Intensive Care 2017, about 43% of the patients in ICU with AKI requires kidney replacement therapy, and majority of them require intermittent HD or IHD, and 32.5% require a continuous kidney replacement therapy or CKRT, and very minimal of them require PD, about 0.9%. So what are the best modality is best in intensive care? Is it intermittent or continuous? So for intermittent, is either we can use intermittent hemodialysis or prolonged intermittent HD, PERT, or SLED. And for continuous is the continuous kidney replacement therapy, or CVVH, CVVHD, or CVVHDF, or PD. And CKRT actually has been shown is the most preferred use in more than 75% of patients in intensive care. And this is just to highlight to you the spectrum of CRRT, PERT, and intermittent hemodialysis. And you can see that the continuous kidney replacement therapy are mainly used for hemodynamic stability and also those patients with intracranial pressure or any brain injury, and those patients who has risk of infection and immobilization. However, for intermittent hemodialysis, it is best for if you want rapid removal or fluid removal, or you want to correct the acid-base correction or potassium or hyperkalemia, is best to perform intermittent hemodialysis rather than CKRT, because CKRT is quite slow to correct this metabolites effect. So this is just a table to by the Acute Disease Quality Initiative, or ADQI at Key, looking at what are the to tailor what are the first option, second option in patient who has are critically ill. Like I mentioned here, in patient who are hemodynamic stability or acute brain injury or intracranial hypertension, it is best to perform CKRT, continuous kidney replacement therapy, or PERT or SLED. And this is acute kidney injury guideline to show you that it is better to use intermittent kidney replacement therapy for hemodynamic unstable for CKRT. So I'm not going to read into detail this slide, just to highlight to you what are the factors to consider for kidney replacement therapy in terms of the severity of the AKI, the necessity whether the kidney replacement therapy is required or not, of the potential risk of kidney replacement therapy because we need to put a vascular access, and the patient may be sepsis, coagulopathy, and thrombocytopenia. So there's a risk of bleeding when you put a vascular access in this group of patient, and other factors like availability of machine, because some hospital in the district hospital or rural area, they may not have a CKRT machine or SLED or PERT machine. And timing, this is just to all in all to highlight to you, this is the key randomized control trial, whether we should start early or late initiation of kidney replacement therapy. And this is the landmark trial, and the latest one is AKK2 in 2022. So all in all, just to highlight to you, all these paper shows that there actually is no difference. Either you start early or you start late. Of course, in Elaine trial 2016, it shows that early kidney replacement therapy is preferable, but there are limitations in this paper where the number of group are very small, only one center, and majority of those patients are surgical patients. And it does not really tally with our own population in Malaysia, where our main bulk of AKI intensive care is usually sepsis and infection. And what are the, I know you all are not nephrologists, but just to show to you the critical element of a continuous kidney replacement therapy is on the modality, anticoagulation filter, and the dialysis dose. And this is just to show the table of different modality of kidney replacement therapy in terms of the ultrafiltration and the prescription of the dialysis for this group of patient. And which CKRT modality to choose, like I mentioned, it depends on the device that you have and what are the technical aspect or the delivering dose that you want to anticipate in these patients. And just to one slide on the filter, you know, the dialyzer. Now there's a lot of new dialyzer coming up, and of course it comes also with a high cost. In the intensive care, sometimes you want to provide the best therapy for the patient, and there's a dialyzer or filter which is cytosorb or auxiliaries where it can improve the patient survival, but RCT showed that cytosol actually there's no sufficient evidence, and our own personal experience of using auxiliaries in intensive care are not so promising. Maybe we are not capturing the patient early in starting this auxiliaries hemofilter, but actually the challenges is it is very expensive. So that's why we are very restricted on using this hemofilter in our patient in intensive care. And also anticoagulation are very important in our management of chronic AKI in our intensive care, where majority or some of them have coagulopathy. So we have quite a challenge of dialyzing the patient using anticoagulation. Sometimes it's best, of course, to do PD in patients who have coagulopathy rather than using hemodialysis. But of course, PD, there are also the intensivists are not happy because it will have some impact on the ventilation setting when we put increase intraperitoneal pressure with the PD fluid. And the dose, I'm not going to dwell into detail. So we have guidelines also, what are the prescribed dose that we want to give the patient when you provide the patient on continuous kidney replacement therapy. And of course, when we initiate CKRT, we also need to know when to discontinue. And this is because it's also an expensive therapy. And this is the clinical indicator. So whenever the vessel pressure starts to wind down and cessation and the increased uric output starts to come out without diuretics of more than 500, and the blood pressure is more stable, and patient is also euvolemic, then I think we should consider to discontinue the continuous kidney replacement therapy. So in conclusion, ladies and gentlemen, in Malaysia, in our Malaysian population, about 24% of patients admitted to our intensive care has AKI within 24 hours of admission. And especially it will be higher if patient has septic associated AKI. And AKI and CKD are closely related. There are also AKI is also a part of spectrum of acute kidney disease. And along the line, if the patients may have AKI, may have persistent or incorrectable EGFR, subsequently they can develop chronic kidney disease. And in AKI, about 7.2 to 43% require kidney replacement therapy. With that, I thank you.
Thank you so much, Dr. Lily Mushahar, for that insightful presentation. Honestly, 40 minutes is not enough to cover all, and we actually have more than that. And maybe we can like one day make a special topic regarding the RRT, because there are a lot to share. All right. So
Thank
your
you.
insights into the latest consensus and management of AKI are not only comprehensive but also incredibly practical in our daily life. Thank you so much, Doctor. So if you have any question, you can write in the Q&A box. I can see there are a lot of questions. However, we will address the question only after our second talk, which the topic is a palliative care for chronic kidney disease. When is the right time? We are delighted to have Dr. Rafidah binti Dato Abdullah, a consultant physician and nephrologist currently practicing in Department of Medicine Hospital Putrajaya. Notably, she is the chair of the Renal Palliative Care Committee, which plays a critical role in the National Strategic Plan for Ministry of Health Nephrology Service. Additionally, she represents the Asia Pacific region in the ISN Nephrology Working Group, a position she has held since 2020. Dr. Rafidah is a passionate advocate for improving the quality of life for patients with chronic kidney disease and has made a significant contributions to the field of renal palliative care. Her talk tonight will guide us through the complexities of palliative care in chronic kidney disease and help us understand the right timing for such intervention. So please join me in welcoming Dr. Rafidah binti Dato Abdullah. So Dr. Rafidah, the floor is yours.
Thank you very much, Adila. Can you hear me?
Yes, loud and clear.
Okay, Yeah, because I didn't try obviously this thing early on. So anyway, thank you so much for the kind introduction. I think I would like to thank everyone in this CME Zoom and those in Facebook. There's so many that joined us tonight. So I think my topic is I'll try and make it a bit or get a bit more sort of range, because obviously this is a kind of a not that heavy topic, but like it's the other pole of Datuk Lily's topic, so I'll try and talk around for half an hour so that I think I can see a lot of questions. So I think we'll try and have more discussion in this session. So there's nothing to disclose except for our CME today is not sponsored, and it will be by our own MedTweetMy. So that will go towards running of our website. So a couple of objectives that I want to achieve today is for some of you is something new. So I want you to understand why palliative care should be integrated in nephrology, and it's important, and how to approach things holistically. And also, I think I'll throw in some new terms, something called integrated kidney care, supportive care, and the basics of comprehensive conservative care. And also appreciate the label of palliative care, which is sort of a misnomer that's used in CKD patients. I'll show you what I mean later on. And also towards the end, perhaps, is there a right time? And when do you implement palliative care in renal patients? And this is the outline of my talk. So I'm going to go through what and why and how, and then at the end, the when. And I'll talk a bit about advanced care planning and finish the talk with some real cases. So as an introduction, I think some of you would know that I do have a master's in palliative care, and I'm currently doing a PhD in palliative care. So we know that the whole world, there's a lot of people which experience serious health sufferings, and a lot of people die with sufferings, and a lot of dying were from communicable disease, and 90% of these is the burden of the end of life palliative care. So the approach of end-stage kidney disease, or CKD, has moved from disease-centered to patient-centered, or person-centered, I would say. And CKD patients, I'll show you some statistics, have palliative care needs and really largely unmet. I think just to set the scene a little bit, I think a lot of people will realize that we are facing a huge burden in Malaysia, and we have more than 50,000, I think it probably is more than 60 now, of dialysis patients, and we have more than 10,000 new cases every year. So this is a staggering statistics, and it's really it's a huge economic burden, and the rest, and so on and so forth. So what happens to the end-stage kidney disease management? I think those days we say hemo, every time you reach end-stage kidney disease, you talk about hemodialysis. And now, of course, the Ministry of Health goes to PD, peritoneal dialysis, and a lot of people now is more aware of non-dialysis, which is called comprehensive conservative care. And of course, the only treatment for kidney disease is transplantation. Okay, so I think that sets the scene to how things have evolved over the years. It takes some time for us to actually educate everyone, but I hope everyone who's listening today would change from talking about just hemodialysis as a sort of a default management of kidney disease. So when you talk about palliative care, a lot of definitions, so to speak, a lot of misnomer. A lot of people think palliative care is no dialysis, just leave the patient alone, but that's not true. I'll tell you why and how. And a lot of times it's misleading. Very misleading, because palliative supportive care actually can be and should be provided alongside dialysis as well. So I think a lot of people say, okay, this patient is end stage, the option is palliative care, but that's not an option. Palliative care is the treatment for everyone, all CKD, in fact, all chronic kidney disease patients. So if you want the patients for non-dialysis therapy, you should be saying conservative care or maximal medical management, renal supportive care, and things like that. Also, those are the definitions, the clear definitions. So if somebody say this patient's option is palliative, that's not correct. Okay. So what is the definition of palliative care? Palliative care is an approach. I think I'm going to And if you can't remember anything else, this is a very important slide. When I did my master's, this slide comes like every other slide, you know. So this is very important because it's an approach which improves quality of life of patients and their families facing life-threatening illness through prevention and relief of suffering by means of early identification and impeccable assessment with treatment of pain other than physical pain, psychosocial and spiritual as well. So this is the concept of total pain. You've got the physical aspect, psychosocial, psychological, and spiritual and physical, of course. So these are all the aspects that we need to take care for all our patients. So if you look at this definition, okay, this is a definition for CKD patients. If you look at the supportive care, CKD patients, if you want to you have to improve, you aim to improve the quality of life, and it's based on the principles of the palliative care. So you need to give that holistic care, holistic management to all our CKD patients, okay? And of course, when you talk about non-dialysis care, which is alternative for kidney dialysis, it's called conservative care or medical management, comprehensive conservative care. So that's what it is. So I'll go through a little bit more detail to that. So this is conservative care. It's actually management, every single management except for dialysis. So that's that. So why palliative care is CKD, right? If you think about palliative care, you think about cancer, right? So a lot of times you think, oh, what are we talking about now? Okay, you guys tell me if my internet intermittently becomes unstable, but just try and bear with me. Staying on the 32nd floor doesn't mean your internet is very good lah. So anyway, palliative care is actually used to be cancer, palliative care cancer. And now we know that non-cancer patients or chronic disease patients have got a lot of symptoms. So this is where the palliative care or support is needed in patients with chronic disease. That is CKD included. Okay. So let me show you this graph is actually the mortality of patients. So if you look at the green bar, the green line, you can see dialysis patients have poorer survival when you compare to colorectal breast cancer, for example. So, definitely they need more palliative care, to be honest, if you look at this. Yeah. And the problem, not the problem, the challenge, I would say, for organ failure patients, they have a relapse remitting kind of graph. Okay. So they don't just, die. They don't have a terminal illness where they're ill for the last couple of months of life and towards death. They have this relapse remitting. So maknanya kalau dia masuk ward, they become ill, we think they're going to die, but actually they do okay, but they won't go back to their baseline. So they become a new lower baseline. So slowly over the years, you think the patient's going to go, but the patient is still there talking to you, but they clinically will deteriorate over the years. So that's why sometimes towards the end of life, you have to be, as nephrologists, we have to be able to pick up when that's going to happen. So if you look at the statistics, to be honest with you, we are, as nephrologists or any kidney or any doctor, we're not very good at asking the right questions in terms of palliative care. These are the symptoms of palliative care, the holistic symptoms. Okay, we don't ask these questions. We, as nephrologists or any doctor, we look at the urea, the creatinine, the potassium, and whatnot. But actually, these patients still have a lot of symptoms. And, you look at it, the statistics is staggering. Whether you dialyze the patient or you don't dialyze the patient, they still have the symptoms. And dialysis does not answer your prayers. Yeah, you may improve the urea, but what does improving urea means to the patient? Nothing much really. So sometimes when you talk to the patient, when you discuss the options with the patient, you must tell them dialysis does not solve your symptoms, to be honest. So you really need to discuss properly. So we need to move away from saying like, look, you have to dialyze, if not, you're going to die, things like that, which we, probably 10, 20 years ago, we'd say that. But it's not that way. We understand now that even you do dialysis in certain kind of population, of course, they will still experience many symptoms. And it's a myth that, dialysis is going to settle all problems. So, what we want, or what we think is important, the urea, the creatinine, the potassium, the pH, the bicarb, is nowhere near important or nowhere near what the patient wants. The patient is thinking about other things. We don't think the same as the patients, to be honest with you. So, we need to be kind of in line And to do that is not easy. So we need to make shared decision makings. Of course, we need to think about the patient and the family as well. The family is very important for patients in our country. So where does palliative care sort of integrate in nephrology actually throughout the journey, which I'm going to show you later. But towards the end of life, this is really need to be enhanced. Like for example, if the patient stops dialysis, they're well and then they got worse, and then we may think about stopping. Or we think that maybe we're not sure, maybe dialysis you do okay with dialysis, we can do a time trial, but prognosis is very poor. Or the patient who decide not to do dialysis at all, so which is called a conservative care pathway. So how do you do palliative care in kidney disease? Just now I mentioned about the term kidney supportive care. So kidney supportive care is the whole umbrella. So you have these palliative care principles which is integrated into the nephrology care. But in that umbrella, the supportive care, it has everything. It has end of life care. You should be able to talk about symptom management. You manage the symptoms. You have to really do proper communication, shared decision making, advanced care planning. I'm going to tell you about later on. We have a multidiscipline. Of course, in Malaysia, sometimes you are the nurse, the nurse that we have, but you're a dietitian, you are the social worker and things like that. You are like, 10 in one anyway. Yeah, but that's how life is, unfortunately. But these are the bigger umbrella. So we need to support our kidney patients all throughout the journey. So it's supportive care. You like it or not, we as nephrologists are with the patient along the way. And every single moment, every single time, every single life decision, all the way throughout the journey, you should manage the social, the emotional, spiritual, and give them proper information for them to make decisions. Okay, so it's very important from the beginning until the end, unfortunately or fortunately. So just to show the graph, the diagram on the left here, when you start dialysis, you're aiming for curative, you're aiming for best, great quality of dialysis and things like that. But towards the end, you probably need a bit more supportive care, a bit more palliative care. And the blue graph here, you actually at some point when the prognosis, when we think is less than a year, I change the goal focus. Instead of having a conventional approach, which is, you look at the KTOV or clearance, you look at the, this and that, I go towards symptom control. We talk about goals of care and we talk about what you want and things like that. Sometimes towards the end, I'll let them do twice a week, things like that, or cut short the dialysis, depending on what the actual individual patient needs. Yeah. And when do I withdraw dialysis? Yeah, we do. Yeah. It's not the easiest in Malaysia. Of course, this is not uncommon in the West. If you look at the statistics, you're talking about 20% of patients actually withdraw dialysis. A lot of times it's medical reasons, but up to 10% is actually voluntary. So they just, they don't want dialysis anymore. So decision to withdraw dialysis also is not desperately easy. And it really involves everybody. You need a consent, you need a shared decision. And actually continuing dialysis is much easier than withdrawing dialysis, to be honest. And when you withdraw a dialysis, it does not mean you, stop treating, stop caring. So withdrawal of treatment does not mean withdrawal of care. So this is I just remember this lady, Arwah, she just loves to take lots of limau. I can't help it. She just loves to take limau. So she becomes fluid all the time. So I remember one time there was banjir and I got a call from someone from Mercy who saw her at home, saying that, oh, Dr. Rafidah, I remember you, but I'm fluid overload now and, she can't come to the hospital. But eventually she managed to come to our hospital after the flood subside in a very fluid overloaded state. I think she died eventually from from infection, things like that. So, she didn't want dialysis, but towards the end she did have, but, she didn't last very long. So, I mean, that's her choice. We have to respect that. So that kidney supportive care I was talking to you about, the holistic care and everything, is actually part of the bigger picture again, which is integrated kidney care. So whatever you do, whether you do CKD, you heard about AKI, AKI in the long run, you have a higher risk of CKD. Then you go into PD. You choose PD first, and then you fail PD, you go for HD, and you get a transplant. And you withdraw dialysis and all that. Whatever you do, you see the green box there, you need to support the patient. So the whole thing is called integrated kidney care. If you look at the integrated kidney care program, it's actually part of the universal health coverage. Not just the dialysis issues, but also everything else about screening, detection, primary prevention. That also needs another discussion, but this is part of the whole bigger picture of management of kidney disease per se. So if you look at that one was the withdrawal, but when you look at who do you do conservative care, means who don't you offer dialysis? What is conservative care? So conservative care is actually those who you do everything else except dialysis. Not the ones who deny. Malaysia ni lebih penuh dengan orang yang tak nak dialysis sampai lambat. So you really have to differentiate between that group and patient who actually properly not for dialysis. So this is a very difficult part to decide. Okay. But it's individualized, of course. Yeah. So what do you do when patient, for non-dialysis care, you delay the progression as much as you can. You do proper discussion, proper shared decision making. You manage the symptom, you communicate, you give psychological support, social support, everything support, the holistic support. You give everything except dialysis. Yeah. And how do you select for those ones who probably shouldn't do dialysis? So these are some of the groups. Of course, again, it's individualized, and of course, it's shared decision making. Those with cancer, those with elderly multiple comorbidities, with multiple liver organ failures, with those with multi-organ failures, for example. I'll go through this in a bit. I'll show you some statistics. Those who actually in the elderly group. Let's go to the elderly, okay? Age is just a number. I would like to think I'm 18 years old all the time, but of course, I'm not. But as much as possible, in the elderly, of course, the definition is 65. But I think the age, the aging population in Malaysia is going up. Obviously, we know that, and we're going to be facing with these issues. Yeah. Whatever we do, we have to be, for those interested, you can look up this core curriculum by AJKD. I think it's very, very good. When you look at person-centered care for older adults, actually you need to understand what they want. Avoid talking about just dialysis as a default treatment. So I think for those older adults, really have to sit down and discuss the options, what they have, depending on their symptoms as well. So just in a nutshell, if you look at this, albeit this is prospective, of course you cannot randomize, one tree with dialysis, one tree without dialysis. But in patients above the age of 75 with multiple comorbidities and age 80 with poor performance status and things like that, the survival is not there. So it really depends how you discuss and what are the goals of care, or what do they want, the individual want, and whatever you do, the family needs to be with you on board with the decision as well. So going back to this statement that I talked about in the handbook, where you talk about the elderly with maybe age 75 and above. So for those who actually have no high comorbidity with a slow renal function decline, which is less than 3 ml per year, I usually don't offer dialysis. So if you're very interested in this paper, they suggested conservative care. For those with very fast progression, you may consider dialysis. Of course, they cannot cope with the symptoms. But even for AKI, if they're high comorbidities, they've got multiple infection, got multiple problems, if they have high comorbidities, I usually do not offer dialysis as well. So it really depends on how you discuss, how you choose your patients, and make your decisions together with the family of the patient. So to dialyze or not to dialyze, the treatment is individualized. So age is not a contraindication, but of course the significant comorbidities are age and comorbidities, yeah. But in Malaysia, actually, to be honest with you, even though you're young, you've got so many comorbidities already. So again, I feel that even at the young age, you multiple, comorbidities, if you're blind, you've got stroke, you've got bilateral amputee, you really have to think about whether dialysis is a good option for you. So whatever you do, we have to do shared decision making between you, between the patient and the family. You need to decide together with them. You can't make decision on your own. Yeah. And now comes to the question, when is the right time? Okay. There's no answer, to be honest. Whatever you do, it needs to be person-centered care. We don't treat the urea, we don't treat the creatinine so much. We treat the patient. It used to be patient, disease-centered and then patient-centered. Now we look at the person as a person. What do they want? Yeah. And again, there's no right answer. So everybody's individualized, right? Not one person is the same as the other, to be honest with you. So how do you do this? It's actually very simple. Throughout the journey of the CKD, the first part, you may be able, as a kidney doctor or even the family care, family physicians, you should be able to give primary kidney palliative care. You see, if you look at the red, graph here, the red part, so you should be able to do symptom management, address the goals of care. But when the symptoms get worse, this is when you need probably more specialists in terms of palliative care, or those nephrologists who've got some palliative care training and things like that need to manage, because it's not going to be easy. Only 3 skills are needed: person-centered communication, right? Listen to the patient, respond to the patient, gain the patient's perspective. Second skill, you talk about goals of care. What exactly do you want? Yeah. And the third skill is just basic symptom management. If you can't treat the fluid overload, the patient's not going to be well. So they're going to want dialysis, to be honest with you. If they keep coming in with shortness of breath, they keep coming into the hospital, they're not comfortable, they're going to come back to you. So if you don't treat the symptom well, obviously they're going to want dialysis or change your mind or whatever it is. So as nephrologists, we should be able to manage this symptom management, communication, and talk about social issues. Like it or not, if the patient's husband run away, patient's wife run away, it's actually your problem too, unfortunately or fortunately. But as nephrologists, we are already dealing with this, on day-to-day basis, because the care needs family support. There's no way the patient can face dialysis alone. Yeah. And conservative care, you need medical management and really focusing on quality of life. Of course, when the symptoms get worse, you really need your fentanyl patch, morphine. I mean, I'm comfortable doing it myself, but for some who's not comfortable, I think the palliative care physicians are available. I think they are quite good coverage now throughout the country. The hospices, they could help you in that respect. Yeah, but the symptoms need to be properly managed. So I just want to finish, this short session with a couple of words on advanced care planning, and a couple of cases to illustrate, my work, what work that we've done, and probably give you an idea of how things can be managed. So advanced care planning, I think some of you have heard that this has been launched in AMM, Academy of Medicine, in August. And in the nephro part, I've suggested that advanced care planning, which I'm going to show the form later, is a discussion, part of integration when the patients develop stage 5, which is EGFR 15, and perhaps repeated every year. And when they're on dialysis, we do that as well. And if the dialysis gets more, we can actually repeat these advanced care planning discussions. So I'll show you what they are. And document, this is not legal, okay? You really still need to treat professionally if they come with symptoms that you think may benefit from active management. But this advanced care planning and non-dialysis care actually are presented to the muftis, yeah? This is the mufti meeting. This is very daunting. You face with some muftis from some states when you talk about non-dialysis care. So actually they asked me, doctor, if you actually know the dialysis do not benefit your patient, why are you still doing it? So bila mufti tanya you soalan macam tu, you be like, okay. Yeah, so I think we have to be very clear. If we as a healthcare professional rasa dialysis tu tak benefit patient, we shouldn't be offering it. Okay, I think it's our decision. That should be okay. Yeah, I think we need to have ability to communicate this with our patients and families as well. So this is the advanced care planning form that I propose that we're going to use quite possibly. What I want to say here that there are questions about CPR, there are questions about ventilation, there's question about dialysis. Do you want dialysis when you're unwell? And of course that the patients. This is the modified pulse, one of the forms that's been used in the I think in the UK. So this will be in some suggested to be in patient's book and things like that. But again, this is not legal. So if the patients come uh with something, even though you said not for CPR and all that, but if the family comes and say no, you have to do it, then the discussion you this can be overridden. Yeah, so be careful also with this form. But this also has been shown that it's good to have communication using these forms with the patient. So I'll finish up with a couple of cases. I've got a 68-year-old lady who loves to cook. CKD stage 5, admissions with fluid overload, then came and lived dengan anak dia kat Putrajaya. Admitted to me around August. Actually, patient memang tak nak dialysis. Masa tu creatinine 1,200. The reason dia tak nak dialysis is because dia jaga husband dia for 6 years and she saw the husband's IJC was bleeding, she saw the fistula was bleeding, and she was really scared of hospitals, needles, and bloods. She really scared. She was very clear. She gave birth to 3 beautiful girls at home. So she hated everything. So during COVID, she decided to stay in Putrajaya. So it's very easy for me because she stayed next to the hospital, so we could visit her at home. And I use IPOS, which is a form which we are now validating and translating to Malay. Dalam tu ada soalan-soalan holistic care lah, your psychological, emotional, social, and all the symptoms. And initial scores were high, but towards the various visits, the symptoms come down, and she passed away around 11 months after the first. I think 11 months after the first presentation to us. Ingat the first criteria was 1,200 So she got 11 months. So that was good. And then I think anak dia, she loved to cook, and anak dia had a bakery and in her name after that. So we do bereavement sessions as well with the children after that. So this was managed together with palliative care physicians next door, which I'm blessed with in IKN. So I have colleagues who visits at home. So this is another lady. She started hemodialysis for a year. Unfortunately, she had lung cancer stage 4, and she had a fractured neck of femur. So when she had that, she couldn't go for dialysis, and she was given a chemotherapy, which she improved initially. And I said, look, I discussed with her. She's a very good, very ex-professor, things like that. She's very compass mental. She's very aware. So we decided to do home hemodialysis, because we know that she's going towards the end of life, but we don't want to stop dialysis, and it's not right for me to change her to PD, for example. But she couldn't go back to dialysis center 3 times a week, so we opted for that, and she got about 9 months, 6 to 9 months, I can't remember, and she finally passed away with upper GI bleeding. Sorry. So now the third case is actually somebody I withdrew dialysis. She was on CAPD, and she started CAPD in January 2022. She had neck of femur fracture, of course, when she offered operation. She was told that she can get up. After that, of course, she couldn't. That's clear. Once a patient of end-stage kidney disease, goes for operation. A lot of things can happen. She became bedbound after that. So her daughter Intan did a PD for her. So she was deteriorating. So I cut down her dialysis. And before I left for Hajj, I think 1.5 years ago, I stopped the dialysis. I remembered her. I prayed for her. I said, let her go in peace. And one fine day, the daughter heard her, she saw something going up to the sky, and she went to her room, and she was still able to read Quran. She was listening to Quran, and she just passed away in her arms. So that was this lady. It was a beautiful case. This 84-year-old who actually started with PD had a lot of problems, and then went to HC, had a lot of problems. He decided, look, I'm done. That's it. And he was at home a few months, and we visited him at home, and he again passed away. And he was very happy not doing dialysis. Very, very happy. So I withdrew the dialysis here. And this lady never had dialysis. We celebrated her life. She was 84. And we decided she decided she didn't want anything, obviously. She had heart failure, she had kidney failure, but the main thing was a heart failure. And we visited her. I think this is my colleagues in IKN and lovely sons that was looking after her. And she again passed away at home in peace. So she had, and it's very funny I went to her house twice. So when the team goes and visit her at home, the whole kampung ada waiting outside. Look, doctor, can you come and see my mother and things like that. So it's a very interesting lah. We love visiting patients at home. So just a couple of slides towards the end. I just want to show you where Malaysia is in terms of palliative care. We are at 3A. If you look at the whole world, we are still having isolated provisions of palliative care. We need to integrate, which is a higher level, which is 4A and 4B. We integrate palliative care into our day-to-day or normal practice or anything. Okay, we need to do that. That's part of a universal health coverage. And just to share with you, we have done a lot of things in terms of the nephrology services, and I'm chair for the integrated renal palliative care for the whole country, and I've seen progress throughout the nation. Thank you very much for every single one of my colleagues. I think they're very good at managing patients already, and I'm very proud of them. And now we're moving into primary care. I think some primary care, especially Terengganu, and I went to Sabah, lovely management. I think you guys are really on board with it. I think, and this is of course we cannot do it alone. We need all your help, and we've got everything. Inshallah, ada CPG of comprehensive conservative care in advanced kidney disease, non-dialysis patients will be coming up next year. I'm chair for that as well. So hopefully we have everything in place for us to move forward together. So in conclusion, ladies and gentlemen, I don't want to talk too long, but I hope I've alluded to you. I know you wanted me to say when to not dialyze patient. I don't have answers to that, because palliative care is not no care. Palliative care is not no dialysis. So palliative care is actually a holistic care. Psychological, emotional, physical, social, spiritual, everything. And no one time is the right time, and there is never a wrong time. Okay? And whatever we do, it should be integrated in our normal day-to-day clinical practice. And palliative care should be given to all CKD patients, and should be given, to be honest with you, to all patients, especially those with chronic disease. I think we can do this. I think every single one of you listening, whether in this Zoom or in Facebook, I think we can do this together. I think you've hopefully know I think to be honest with you, you're already doing it already. You are already doing it already. Once you give support to my CKD patients coming to you, I think that's excellent. That's good enough, because sometimes they just need to be listened to. And because the CKD journey is not easy. And it's not easy. And with that, I would like to thank you. I'm starting a podcast. I think I've done a few, some on Facebook. The first one with Dr. Alex from Ipoh. I think I'll be putting it on YouTube. Hopefully, bila ada masa lah, obviously. But I think with that, I would like to say thank you for everybody's support. whoever you are, whatever you are, whether you are a healthcare professional, whether you're a nephrologist, you're managing kidney patient, primary care, working in the lab, families, anybody. I think you've done a good job. I hope we can do this together. With that, I thank you very much for listening, and I'm happy to answer any questions that you have. Thank you again.
Thank you so much, Dr. Rafidah, for such detailed and interesting talk on palliative care in CKD patient. I think this is quite new topic in our, practice, and it's not well explained, and actually it's very interesting, and your presentation is, spark some idea to our practice so that we can apply it, inshallah, one day. So I just remember one thing is, no one time is the right time, and palliative care is not no care, is actually a holistic care, regardless whether it's CKD, cancer or anything, is actually need our best most support. Okay, so now we move on to our Q&A session to discuss any question from the audience. I can see we have actually more than 30 questions, and Dr. Lily has been answering few questions online as well. So with that, I'll pass the floor to Dr. Faiz to facilitate this session. So Dr. Faiz, the floor is yours.
Alright, thank you, Dr. Adila. And again, thank you very much to both our esteemed and respectful speakers, Dato, Dr. Lily and Dr. Rafidah, for the insightful and exceptional lectures. Hi everyone, my name is Faiz Mushahar. I'm going to host the Q&A session tonight. Beforehand, we would like to take this opportunity from CME MedTweetMY to give our appreciation to all the participants. We have registrants more than 1,000 tonight for the support for our CME, our last CME in fact tonight. So we have tons of questions tonight, but kind reminder and a bit of disclaimer. This Q&A session is not a clinical consultation, and any doctors who like specific answers for a specific clinical situation is advisably to consult directly to the in-charge nephrologist for more accurate and appropriate advice. And some of the question has been answered by Dato, Dr. Lily. So I think now we start with the first question. All right. I direct the first question to Dato, Dr. Lily. For patients with AKI or underlying CKD who need urgent CT scan, how would you proceed? Do you give IV hydration pre and post CT scan? Because I read from a joint statement from Royal College of Radiologists and Emergency Medicine that the evidence of fluid therapy prior to contrast is weak.
Yes, thank you very much. So based on there's a few studies looking at fluid resuscitation, NAC, and even sodium backup before, and all are actually very weak evidence. But fluid resuscitation or hydration actually is one of the only thing that we can actually try to hinder the patient from developing acute kidney injury. So if the patient is planned for CT scan, sometimes urgent, you do not have time to resuscitate this patient, especially if the patient has AKI and oliguric. We are worried about fluid overload. So fair enough that you first thing that you need to remove if the patient, to make sure the patient is not dehydrated. Like if the patient has chronic liver disease, heart failure, they are at risk to develop contrast-induced nephropathy and even diabetic patient. So what we do is if the patient has a good normal kidney function, we will resuscitate the patient accordingly 6 hours prior to the contrast, and also at least 2 hours post-contrast. And we monitor the serum creatinine, because AKI starts to develop at the peak at day 5 post-contrast. So to me, to us, nephrologists, we still resuscitate, but we need to judiciously look at the patient holistically as a whole to make sure that we don't tip the patient into fluid overload.
All right, thank you, Dato. Yeah, the key point here is the contrast-induced nephropathy peak at day 5. So need to treat, all right? So the
Faiz, nak tambah sikit. Kita duduk borak-borak lah.
Boleh.
Kan Lily, I still don't understand. Maybe some of the requests is actually to do kalau HD patient or whatever, to do HD after the contract. Okay, I still don't know why people think that way. So I don't think for those who's working in the X-ray radiology department, we don't do HD specifically after contrast. Of course, you
Yes,
think
that's
about
the
the fluid
proof.
overload, things like that,
Yeah.
but we don't. There's no indication. Can we like please stop it? Like okay, thanks.
Okay.
Itu je.
Thank you, Rafidah. Okay, so I think moving on to the next question, I direct this to Dr. Rafidah. For patient in septic shock, despite fluid resusc, still oliguria or anuric AKI, and now patient has overload features. What's your take on giving IVI Lasix, Dr. Rafidah?
Okay. So IVI LASIK, I don't know, Lily, whether you do have any evidence you can add on if you want. But I personally kalau I bagi LASIK tu it does to me, it does work clinically, and if it's actually to buy time. Yeah, so I give if you're already septic shock, obviously you are on inotropic support, and I do give sort of infusion or something like that practically. But you must remember, septic shock sometimes, it's very difficult to turn around. So sometimes your furosemide also doesn't work. So it really depends. Kan, Lily, kan?
Yeah. So my practice is in AKI, we challenge with furosemide at least 48 hours. Because sometimes we, like Dr. Rafidah said, it may buy time. And once the kidney function starts to open up, sometimes actually the AKI will hinder from starting on dialysis.
Alright, okay, thank you very much. So moving on to the next question. Slightly out of topic, but because there's a slide on SGLT2 inhibitor just now, what's the lowest eGFR that we can tolerate to start, this SGLT2 inhibitor?
So based on the empat kidney, dapat CKD kidney, our eGFR tolerance, because it's evidence-based, the lowest is more than 20 mils per minute. However, if the chronic kidney disease progress, where slowly the eGFR to drop further, we do not stop the SGLT2 inhibitor. You still can continue. But once the patient start on dialysis, which is end stage, then I think we can stop. Some cardiologists, they would like to continue at SGLT2 inhibitor, even though they are already on dialysis for cardiac protection. But for us nephrologists, once the kidney already has no effect on end stage, for example, then we just stop the SGLT2 inhibitor.
Lily, kita tanya cardio trainee ni, Faiz. You guna kah?
Yeah.
I mean,
Yeah.
for more than 20 years we use. And again, if the eGFR worsen over time, sometimes we continue. But for those yang end stage, if you want to use, we advise as off-label. That's my practice.
Yeah.
Yeah. Correct. So another also I need to comment here. Also, just to remind everyone, this is practical. Is using SGLT2, you have to discuss about the side effects. I think a lot of people don't do that. And also just now you were talking about the contrast. Actually, to be honest, if the patient come in for contrast or if they're ill, they already got CKD, the things that I stop is SGLT2 and ACE inhibitor or ARB temporarily. So when we do start stuff, we also need to know when to stop stuff. Yeah, itu
Okay.
saja.
Alright, thank you, both our speakers. So now moving on to the next question. Since we talked about ACE and ARB just now, is there any cut-off or specific in the guidelines when to withhold ACE inhibitor? For example, withhold until we completely decongest patient, or we need to withhold once the creatinine increase more than 25% from baseline?
Okay. Like Dr. Rafidah was saying that sometimes we need to know when to stop stuff. So if the patient develop AKI, because of this, and we are putting on diuretics for decongestion. If the creatinine starts to go up, sometimes we are not sure, is it because of we are over diuresis causing ATN, or is it because of the drugs? But if the creatinine is worrying more than 25% or 30%, albeit or even more than 30%, then it is advisable to stop your ACE inhibitor and also SGLT2 inhibitor. And you can continue to the furosemide if you're worried about the patient is still overload. So I would temporarily withhold the ACE inhibitor and SGLT2 inhibitor, but subsequently after the AKI resolve, please do not forget to restart back, because these two drugs is the two pillars to retard the CKD progression. Some of us tend to forget to restart back those drugs after the acute insult has been resolved.
Yeah, they're very good at stopping, and then they're very good at stopping and not restarting. So I think they are only the other practical thing that is I don't agree or I see people do is actually starting while they are inpatient for something. So if they're admitted for something, for example, fluid overload ke, you're admitted for sepsis ke, you don't start ACE inhibitor or ARB then. You start when they are stable. Betul tak, Lily? I ada
Yes.
orang suka sangat start masa orang unstable. Tak
Yeah,
faham
not
saya.
unstable. Yeah.
Tu, okay, so tu saja komen.
Okay, thank you. So now, I mean, on managing AKI, sometimes you use furosemide. Is there any specific guideline on how to use it judiciously? Because I mean, certain nephrologists or sometimes even physician, they have their, I'm not sure whether personal preference 40, 80 TDS, and what is your cutoff to differentiate AKI due to cardiorenal or AKI dehydration?
AKI dehydration, I think if AKI because of dehydration, we can assess whether the patient is clinically, if the patient is dehydrated or not in terms of hypotension and there's acute insult causing the dehydration and like assessing the skin turgor. However, the furosemide, in patient who are in intensive care, I would prefer to give infusion, where it's continuously we are tickling the kidney to produce urine rather than boluses, especially if the patient is hemodynamically unstable. But if the patient is stable, blood pressure is quite good, then you can give boluses from, maybe you start low first, 40 TDS. If it doesn't work, you can push up to 80 TDS. So I think it's the preference from the individual physician or nephrologist.
Ya, nak tambah. So actually furosemide ni tidak mengganggu prognosis seseorang, CKD. So you actually treat the symptom. So some people, some people ada sangat terlebih anxiety kalau creatinine tu naik dengan furosemide. So saya tak ada anxiety tu. Because, because if you expect the creatinine to go up with furosemide when you're fluid overload, right? You give furosemide, you are supposed to. So, banyak orang fikir, it's AKI, interstitial nephritis lah from furosemide. I'm like, what? You at the end of the day, you decide lah, you nak treat the patient ke, you nak treat the creatinine. Kan? So, so banyak, too many anxieties I see with, worsening AKI with furosemide. I think that's unnecessary. Not necessary.
Okay, all right.
So, terutama cardiology. Sorry, saja nak kacau.
Okay. All right. So, okay. So there's one question on renal biopsy. Is it true that long side effect of renal biopsy can cause renal failure?
I answer first, Rafidah. No, unless it cause trauma, like thrombosis, hematoma, needs embolectomy, and some when you embolize the kidney because of the bleeding, it can cause a sub-infarct. We're not sure how big is the ischemia of the kidney when the embolization is being made. However, if there is no complication from your biopsy, just imagine there are millions and millions of glomerulus. And when we biopsy a kidney, the glomerulus, the most that I saw, we managed to get is about 20 glom. So it will not.
I pernah dapat 100 lebih.
Oh, I know. So that is really
Sangkul.
nephrectomy. So, but no, it does not. Kidney biopsy does not cause AKI if there is no complication from your biopsy procedure.
Okay, good, understood. All right. So next question would be, what is the question? Okay.
Banyak soalan, Faiz.
Itulah.
Penting kan?
Okay. And got one question on lactic acidosis. Just now, Dato got mentioned about bicarb ICU trial,
Yeah.
usage of bicarb in metabolic acidosis. What if it's in the case of lactic acidosis, and
Yeah.
is there any role for bicarb in oliguric or anuric AKI?
Yeah, lactic acidosis is different from metabolic acidosis. Lactic acidosis usually occur due to tissue hyperperfusion, especially in sepsis or dengue patients as such. So the main thing is to hydrate the patient adequately and to improve the tissue perfusion. We do have patients, especially during the dengue season, that they are they develop AKI, lactic acidosis, and we initiate the CKRT, the continuous kidney replacement therapy, and the lactate does not come down. And it will not recover because our dialysis only improve the metabolic acidosis. So it's high lactate, and if it doesn't improve, it's very high mortality.
Okay. And for the anuric or oliguric AKI, sorry, the sodium bicarb.
Oliguric AKI. Okay, be careful when we give IV sodium bicarb. Please look at the serum sodium first. Monitor your serum sodium. If the patient is hypernatremic, please do not give IV sodium bicarb. Or number two, if the patient is fluid overload, also be careful because when you give sodium bicarb, quite a number of sodium bicarb, you tend to tip the patient into fluid overload. So if the patient is oliguric, you can initiate with, of course, one boluses, maybe it's okay 50 cc, but infusion of sodium bicarb, you need to be careful to look at this hypernatremia and the fluid overload.
Okay, all right. So I think next question for Dr. Rafidah. If let's say patient not compliant to his dialysis, is it ethical for us as a doctor to withdraw?
Tak boleh. Tak compliant tu biasa. Okay, so ada tak patient yang compliant? I don't know lah. I mean, okay. So the short answer, long answer. That was just So patient is not compliant to dialysis. There's so many reasons. So the patient does not come for dialysis, for example. So instead of doing 3 times, they buat sekali atau 2 kali. So we need to discuss reasons with them lah first, to find out why and address the issue. Sometimes maybe dia tak ada transport, sometimes dia kena kerja, sometimes kalau dia tak apa datang dialysis kena buang kerja, those things. But at the end of the day, we need to discuss also the complication, because kalau they cut down dialysis now, they don't have the complication now. They're going to have the complication, a few years down the line kalau dia muda lah. Kalau, kalau dia selalu fully overload, sekejap je dia masuk dekat hospital, masuk ICU dan sebagainya. Lepas tu dia akan tersedar sekejap. And then dia balik compliant. So, it really depends. When somebody is not compliant, we need to discuss or see holistically what is the problem. So, if really cannot compliant, we have to accept that they have to share our decision with them. Look, one day you're going to develop this. It's very difficult for us to sort this out. So you have to accept that and you document that properly. But I don't think we should be withdrawing lah. I don't think that's unless there are other reasons to withdraw. Patients already ill, medical reasons, things like that. Yeah.
Okay, all right. Thank you, Dr. Rafidah. And many raised interest in the form that you shared just now. So is that form made available in our local hospital, and can we use it actually?
Okay, so that form is called ACP form. I think talking about ACP form ke IPOS form ni? Banyak form tadi. Ya, ACP ke? Or IPOS? Yang palliative care one.
I
Yeah.
think the ACP one, not the
Okay.
IPOS, because IPOS is readily available, right, Doctor? It's
So
everywhere.
ACP, okay, so sebab this ACP has been pushed to be launched, last year, last August by the palliative care and many other people, and I think everybody is involved, the ED or surgical. I think surgical pun ada dalam team tu, FMS, all the rest of it. So there is a standard pulse form, and then there is also a standard pulse form tu macam already ada dalam internet, and then we sort of I modified that, and hopefully it will be agreed in our nephro meeting, which is next month. No, bulan 2. So if we agree to that form will be I will help train people to do it in nephro patients. Eventually, I mean, I cannot just, lash it to you and okay, you do it. Tak boleh. I think we need to train, we need to be sure how you. And also the Mufti, okay, I have to say what the Mufti say. The Mufti said, if the person doing the form doesn't understand the form, it's also going to be very difficult. For example, if I clearly say, like I said, I don't want CPR. I memang tak nak CPR lah. Mungkin kalau I collapse, kalau orang CPR, I bangun kat you, CPR you, I don't know. So, but for example, if I have an MI with VT, VF, I'm sure you're going to CPR me, right? I mean, even though I say no CPR. So that form is not legal, to be honest. Yeah. So you still need to CPR or you need to shock me if I get VT or no, I mean, whatever lah, whoever lah, kan. So I think that form will be there in nephrology. I cannot answer for other organs, the heart, the lung, because they're all there in the group. For nephro, we'll start within our fraternity first, within dialysis patient first, and eventually in the CKD stage 5. Because I can see a lot of patients are in denial. Okay? Because they don't want dialysis until it's very late. Tapi dia cakap dia tak nak dialysis. Sebenarnya dia nak, tapi dia nak bila dia lambat. So that form has got a question about what do you want me to do when you come ill in ED. So do you want dialysis or not at the time? So I think that's a very important form. Satu, to communicate. Also about discussing about option, and also to guide those people who actually manage the patient when they come in ill. Hopefully lah. So that's it. So it should be available within the nephro fraternity next year lah.
Okay, all right, thank you. So still got a number of questions. I will pick the most that will give clinical relevance to us. So the next question would be, I mean, what's your approach in discussing with family members in initiation of temporary urgent dialysis? For example, patients with MI and cardiogenic shock.
Temporary dialysis means how do I discuss patient? Okay.
Long term.
Tak faham. Macam mana? Soalan? Macam mana nak discuss acute?
The acute HD, I mean, in terms of discussion point, versus the chronic RRT.
Oh, okay. So acute HD. I think the discussion is very very long. I think a lot of people think acute HD solves the problem. Okay, I had a phone call early today. Obviously he's fluid overload. He does alternative treatment. The usual story, kan? So he's diabetic. He's also got a ejection fraction of less than 20%. Okay, so his creatinine runs around 500. So he comes in fluid overloaded, hospital acquired infection as well with CRP of 80, and he's in shock. He's got VT. He's on inotropic support. So obviously his primary diagnosis is cardiogenic shock with HAI, hospital acquired infection, quite possibly baru discharge, and chronic CKD. CKD creatinine dia sama je 500. Okay, dia tak, potassium dia 5 je. So you see, this kind of patient, urea dia 45 lah, standard lah, So sometimes people think default dialysis. That's not right, the problem with him is actually the cardiogenic shock, the infection. We settle that first, if possible lah, I don't know. Only thing about dialysis, and if there is any hyperkalemia, we manage the treatment. So dialysis in this situation, in a setting of cardiogenic shock, is very risky. Very, very risky. So the discussion about acute dialysis in this kind of case is so much different from another case, which is long-term. It's so different. So the risk of cardiac death and all that. Of course, the risk of HD, a lot of people do not discuss this. HD is actually acute sudden death. A lot of people do not discuss this. Please discuss this. When you do IJC, also discuss the complication about aneurysm lah, rupture this lah, rupture that. So a lot of people do not discuss that. A lot of people, when they develop the complication, and they will kelang kabut. But acute dialysis is more risky than obviously chronic long-term dialysis when you start. Of course, it's risky anyway. So the discussion is very, very long. In fact, recently, I think last week, I had a stage 4 lung cancer. No, stage breast cancer who's dah sorted a few years ago and now recurring. And buat pula CT scan with contrast. Obviously, at day 4, creatinine went up to 1,000. So she's still very well. I have to discuss hemodialysis to make sure that we support her acute event. And true enough, she actually recovered. So the kidney function recovered now. But of course, that will limit her option of cancer treatment, kan? Breast cancer recur and so on. But the discussion about that, in fact, I had to do a Zoom meeting with the son who's in Penang. So even the discussion, it's a very simple acute dialysis. You think it's simple, but the discussion took an hour on Zoom, So a lot of people underestimate the discussions to start dialysis in any setting. Please don't do that because the family, the patient needs to be discussed and communicated very, very thoroughly. So this is where we are lacking. I think not just Malaysia, I think the whole world, the communication part is very lacking within us lah. I think we need to improve a lot lah. I mean, me myself as well. Yeah.
Right. Thank you, Dr. Rafidah. Yes, key point is to emphasize the possible complication and high risk, especially in those acute patients. And moving on to the next question, how to estimate protein intake for dialysis patients and how to advise on it, Dato?
Okay, I think if this is for chronic kidney disease, one of the it has been shown that low protein intake can retard the CKD progression. So it's either low protein intake of 0.8 to 1 gram per day, or a very low protein intake of less than 0.4 gram. But of course, if you put the patient on very low protein intake, we're worried about malnutrition. So therefore now, whenever we advise a patient on very low protein intake of less than 0.4 gram per day, then we will of body weight per day, then we will advise the patient to take a supplement like ketosterol or amino acids to prevent them for developing malnutrition. But of course, ketosterol is very expensive, and we do not widely advise the patient to give if they do not if they are unable to take very low protein intake. But there are studies where shown that the low protein intake from there will be a nutrition guideline coming up in 2025, where we did address that sometimes it's very difficult for patient to take a very low protein intake, and that it might tip them into another spectrum of malnutrition. However, in our guideline, in our CPG, we still advise a patient we refer the dietitian to cut down at least 0.8 to 1 gram per day.
Yeah. I think protein is a big topic in social media. Pening dah kepala saya kadang-kadang. Kita to be honest, we also confuse patient lah, because before dialysis we say no protein. Lepas dialysis kita kata no, low protein. Lepas dialysis kita kata makan banyak protein. I think patient pun macam apa dia. So Faiz betul So anyway, so yeah, I agree completely with Lily. I think we're looking forward to that guideline, and in my CPG comprehensive care pun kita akan sebut sedikit, and we will give contoh-contoh. And the other thing that I also want to touch here is actually we say avoid red meat kan in CKD, tapi bukan tak makan langsung protein haiwan. I think that is completely wrong. Banyak orang tak tahulah sebar mitos apa benda dekat media sosial tu. Yeah, so we cut down. We said, okay, kita kata matchbox kan, matchbox every time you makan sikit macam ni,
Yeah.
But after dialysis you're supposed to take a lot, right? So especially when you're on PD kan, Lily champion PD.
Yeah, but of course we have to look at the NPCR lah. If the patient is quite well, we just advise the normal protein intake unless they are so malnourished.
Yeah.
Level very low.
Yeah.
Oh,
Okay.
I think we need to finish in few more questions because of the time constraint. So, okay. Do you find any difference by adding aminophylline on top of furosemide for renal protection?
No, there's no paper. There's a lot of things in the pipeline also have been done on CKD progression, But on aminophylline, there's no evidence to add on to furosemide.
Okay, all right. So last question. In those with exhausted vascular access, not suitable for any alternative RRT, is there any other option or is it fair to palliate this kind of patient? Exhausted
Okay.
access.
Okay, so basically individualized lah. I think very difficult if they're young. You really have to discuss. To me, vascular access has a few steps towards the last. So before you get to the last, you really have to have that sit down discussion. Look, you are already on your last. What do you want me to do after that? Sometimes patients susah, dia denial, lah. But you really have to sit down lah. There's no one answer to that question. I can see the problem kat Malaysia ni, kita start dialysis awal because they are younger age, they get diabetic earlier. There are these diabetic patients that have very poor vascular access. But I've seen patients on vascular access, cuff catheter for a long time. So really depends on that patient. So we cannot tell. So the answer very short is individualized. I cannot answer for that particular question. Only the person, the patient, the family, and the doctors managing can answer that question.
Okay, and some of our questions also need an individualized answer or need assessment by the nephrologist before we able to answer. So
Yeah.
sadly, we need to stop our learning journey tonight due to time limitation. Any unanswered question, please don't hesitate to contact us via our SOCMED. We'll try our best to reply. Again, a very big applause to both our speakers, Dato Dr. Lily and Dr. Rafidah, for such an insightful session. I hence pass the floor to our moderator, Dr. Adila, for our closing speech.
Okay, we are quite overwhelmed with the questions. We have more than 40 questions, more than 1,000 participants. I guess topic tonight is very hot. It's a hot topic. And the topic, thanks to our both esteemed speakers for their outstanding presentation and for sharing their invaluable expertise with us tonight. So this is like the best ending for CME MedTweetMY for our last CME of 2024. So we'd like to thank all participants for your active engagement and thoughtful questions. So we hope tonight's session has provided you with meaningful insights into the latest developments in nephrology. Please stay tuned for more upcoming sessions organized by CME MedTweetMY Professional. Wishing you all the best in your professional endeavors and see you in 2025. Thank you and have a great evening.